Welcome back. Urinary incontinence is a medical problem, but it can also take an emotional and a psychological toll on those who suffer from it. Here to talk with us about this is Dr. Laurephile Desrosiers, urogynecologist with Doctors Hospital Health System. Good morning and welcome to Bahamas at Sunrise.
Good morning, Mark. It's nice to be here.
Yes, thank you for being up with us dead early on this marvelous Monday.
Raining.
Yeah, right? So tell us, Doc, what is urinary incontinence?
So it's really any involuntary loss of urine. And there are lots of reasons why that can happen. It can happen because there's a change in the intra-abdominal pressure where you cough and you leak, you laugh, you leak, you sneeze, you leak. It can happen because there is increase or overactivity of the bladder, where the receptors of the bladder are essentially upregulated, and so you have these involuntary muscle contractions of the muscle of the bladder, and when that contraction builds enough pressure in the bladder, it can lead to leakage. It can also happen as a result of neurogenic bladder. So there are lots of nerves that go between, our lower pelvis towards our brain, and they're sending signals consistently. And those signals, if there's, for example, a car accident, if there's injury to the spinal cord, etc., that can lead to disruptions in those signal pathways. And as a result, you can have loss of control of urinary function, and that can lead to leakage as well. We tend to call that neurogenic bladder.
So there's neurogenic bladder. What are some of the other types?
All right, so stress incontinence, which is the leakage, which it's not because you're stressed out. You may also be stressed out, but from the stress incontinence.
Right.
But the leakage with activity, typically we're seeing this, in 40, 50-year-olds who, and sometimes even, sooner, especially in that initial postpartum period where, you're running after children and you're like, if I better not get on a trampoline, because if I do, then it's game over. For women who are needing to wear black clothes because when they go to exercise, they already know. People who start to map around where the restrooms are because they know that they need to make sure they're empty with any activity. So we call that stress incontinence. And that tends to be, we tend to see it a little earlier on in life. Like I said, very, very common postpartum. There is an old adage that this is just, basic, this is common, this is what happens. And I like to say, yes, diabetes happens, hypertension happens, high cholesterol happens, but we don't tell people, okay, just deal with it, right? Whereas we tend to have that sort of adage that we're telling women with incontinence. And incontinence can have, not only an emotional toll, but certainly can have some medical issues that can come with it when it's not looked into. So stress incontinence can certainly be bothersome. And then urge incontinence, which we tend to see a little older. We're seeing in 50-year-olds, 60-year-olds. And that causes urinary urgency. That's sort of a sudden, urge to go to the restroom that can't be deferred. I'll have women who say, don't tell me, I know where every bathroom is in this hospital. Or I know where, where I work in the mall, and I know where all the bathrooms are on the first floor. Well, that's a telltale sign that there's something going on, needing to bathroom map. Or women, they'll say, I go to the bathroom before I leave the house, when I get to where I'm going, before I leave where I'm going, just in case. Well, typically it's because we're trying to avoid, accidents. And so there are certain things, and I'd like to say that although sometimes we do have to use sanitary napkins as a way to sort of protect ourselves, there are actually meaningful ways that we can improve our quality of life.
So tell us about some of the treatment options available for some of the women who suffer from urinary incontinence.
Well, first and foremost, I think diagnosing what's going on appropriately is the first thing, right? So there's a tendency to to forget that there could be there are many reasons why we can be having incontinence. It can be because we're having urinary tract infections, and those need to be treated if that's what's going on. It may be because we're not completely emptying our bladder, and we need to evaluate why that is. Is there because there's underlying neurologic issue that's going on, multiple sclerosis, for example, Parkinson's for our older patients, etc. Or is it because that there is, actual, urge incontinence, stress incontinence, etc.? So having the correct diagnosis is really important, and I can't emphasize it enough, because that is going to change the way that we manage things. So once we have the correct diagnosis, and let's say that this is just your good old-fashioned, stress incontinence, then I'm highly going to recommend that we start doing behavioral modifications. There's a tendency for women not to drink enough water because they don't want to have accidents, and they think that drinking more water actually makes them go to the restroom. And I always say, your kidneys are way more important to me. So I want you drinking enough water, and we'll fix the incontinence. Now, then we'll start to include things like, pelvic floor therapy. I'm a big, supporter of pelvic floor therapy, and it's where we use physical therapists that have additional training to work with women to teach them how to do their pelvic floor exercises. You'll notice that I avoid saying Kegels, because every woman has heard, their doctor say to them, go do Kegels. And we literally say, go do Kegels. And then they're like, oh, okay.
Like they're jumping jacks, like everyone knows what to do, right?
But I find that, over 50% of the ladies that come in to do Kegels do them incorrectly. When we're examining women, we'll check to make sure it's being done appropriately. And the majority of them are pushing, or they're using other accessory muscles in order to engage their pelvic floor, and that actually is not the right way to do it. So working with a pelvic floor therapist that's trained, that's going to do that part, do the hard work with you, is really important. That's number one. And then, depending on what type of incontinence, if it's stress incontinence versus urge incontinence versus mixed incontinence, which is a combination of both stress and urge, there are different non-surgical as well as surgical options. So pelvic floor therapy being the obvious number one. Other smaller things that we can do, so I like to use pessaries, or even tampons sometimes. There's a tampon that's specifically made for this, it's made by the makers of Poise, that can be used. There are some online things that can be used as well, which I like to guide patients through, because I want you to use things that we know and we're familiar with. So those are non-surgical options. There are lots of minimally invasive ways of managing stress incontinence. For example, we can do periurethral bulking, which is we use a little bit of material around the urethra. And I don't know if the pictures are up, but periurethral bulking can be very successful. It's an outpatient procedure. You go home the same day. The only thing we say is, avoid heavy lifting for, a few days after the procedure, just to allow things to settle in, okay? And then there is the midurethral sling, which is a little hammock that gets placed underneath the urethra, also an outpatient procedure. Patients can typically expect, no heavy lifting for 6 weeks. It is a mesh material. It is a foreign body that we're placing, so we do have some restrictions in terms of post-operative ability. But in terms of going back to work, most patients should be able to go back to work within a week or so after. The heavy lifting tends to be the most important restriction.
It seems like there's a lot of options available, and it's not necessarily a doom and gloom diagnosis, and that women should reach out for assistance. Tell us how Doctor's Hospital is tackling this issue of urinary incontinence.
So we have a Urogyne program that we're starting. We're starting this week with a whole expo week where we're really pushing and getting information out there. And urogynecology involves, several aspects, right? Not only incontinence, but pelvic floor, an array of pelvic floor dysfunctions, which include incontinence, prolapse, chronic pain. We also want to talk about ways to help women minimally invasively. We do a lot of minimally invasive surgeries, what we call keyhole laparoscopy, small incisions with better recovery, less blood loss, good return to work, etc. So we are really pushing the options for women, and more importantly, we just want women to be educated, because we know that not only having the correct diagnosis is really important, but we also believe that women who come earlier have more options. For example, if you were to have diabetes, and you wait until you come in with neuropathy and a hemoglobin A1C of 13, which means that your diabetes now is affecting every organ in your body, it's harder to treat.
Right.
Whereas if you come in early and you can, manage your diabetes, your high blood glucose rather, then it's going to be much easier for you to have a better, longer success story in that process. Right. So that's what we're looking for our program and our patients. We want to see you early.
Well, we know Doctors Hospital always has a solution. We always have a number of the physicians on the show. And we'd like to thank you, Dr. Desrosiers, for coming on and talking to us about urinary incontinence. Tell us, how can people contact you?
Absolutely. So I'm at Doctors Hospital. You can feel free to call Doctors Hospital, the main line, so 302-4600, and then the extension there is 5557. Or at Centerville Medical Center. I'm there Fridays and Saturdays. I'm happy to see patients. And that number is also 302-3250, and we're happy to see patients there as well.
Well, Dr. Desrosiers, thank you for joining us this morning, opening our eyes to the issues surrounding urinary incontinence, but providing us with encouragement that there are solution options out there and that it isn't an end-all, and that they should come and see you, come to Doctors Hospital. So thank you for joining us, Mamas at Sunrise.
Thank you for having me. It's been a pleasure.
You're watching Mamas at Sunrise. We'll be right back.